All right. Thank you for joining us today for today's event on prior authorization findings in implanted spinal neurostimulators.
My name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education team, and I'm going to be your facilitator for today's event. I'm also joined by other members of Provider Outreach and Education who are going to be helping with the chat as well as the question and answer portion of today's call. So as we move on, just a few housekeeping things as we get started. On our website, which is wpsgha.com, we have a training center. Hopefully this is where you all went out to register for this live event. In our training center, you have access to all of our training material, as well as the ability to register for upcoming events and access our encores, which are the recordings of our live events. We post our most recent encores to our training center page as well, because we have a built-in YouTube player on that page. So you can actually watch these events without having to go into YouTube. These encores and the handout for the encore are generally available on our training center page for 60 to 90 days after the event, but they're always available, the recording is always available on our YouTube page until more current information replaces it. So to find our training center, you would go to wpsgha.com, and then you're going to click on the Training Center tab from the top navigation, and then you'll be able to find the Live Events tab. If you have any feedback about your experience today, there's going to be several opportunities throughout this event and after this event to take our survey. So if you are listening to the encore of this event, watch for that survey link to pop up at the top of the screen at various points throughout the event, and at the end of the event, then there's going to be a link in the description. For today's live event, Jennifer has placed the survey link into the chat, and you can feel free to take that survey at any time. The CMS Qualtrics survey is your opportunity to get feedback on our event, and we want to know about your experience with this event. The survey is your opportunity to not only tell us about your satisfaction with the event, but to also let us know what additional education you want us to provide in the future. On your screen is also our disclaimer on the CPT copyright notice. So you can read this at your own leisure, but we have to give you this copyright notice whenever we use CPTs in an event. And there are some CPT codes listed in this event as we go through. Next on your slide is, or on your screen is our disclaimer. And our disclaimer basically says, you know, we prepared this educational event as a tool to assist you, our provider community. But Medicare rules often change, and it's your responsibility as a provider to make sure you're following the most current laws, rules, and regulations as they stand on the date of service. So we're going to answer questions today based on the facts that you give us and the laws, rules, and regulations as they stand today, because CMS has final determination on coverage. If you have any questions about, you know, other coverage information, you can always access CMS's website to make sure you're following the most current laws, rules, and regulations, and that website is linked right here in this slide for you. Also, we ask that you please do not audio or video record this event or take screenshots of this event. We are actually doing it for you, and like I said, we're going to put it on our YouTube page within 15 business days of this event, and most likely it'll be up tomorrow or the next day. This slide just contains some acronyms that I may or may not use during the course of this event. So if I happen to say an acronym and you don't know what it is, you can just refer back to here. All right. So my objective today is that you, as our Medicare provider, you are able to acquire enough information today so that you can receive affirmed prior authorization requests the first time you submit them for this service. We're going to review coverage criteria, and we're going to discuss documentation requirements, and we're even going to highlight some common medical review findings and how to avoid them. And that's how we're going to accomplish my overall objective of you being able to receive your affirmed decisions on the first request today. So let's talk first about what prior authorization is. So prior authorization is actually a provisional affirmation that's granted to hospital outpatient departments to perform and bill specific services prior to performing the service. So it's asking for permission in advance. The services under the HOPD prior authorization provision include the spinal cord stimulator that we're going to be talking about today. But also there's other services like blepharoplasty and Botox and things like that that also fall into it. The specific services under the prior authorization process, all of those can be found on our website as well as on CMS's website. But today we're focusing on those spinal cord stimulators. So the hospital outpatient prior authorization process is specific to these services, and it's specific to them being performed in the outpatient department of the hospital. And that is on a 13X type of bill. So hospital outpatient departments bill on a 13X type of bill. Ambulatory surgery centers, critical access hospitals, physicians' offices, or any other place of service besides a hospital outpatient department are not included. So if you don't bill on a 13X type of bill and you're listening, you are not obligated, nor should you submit a prior authorization request. And you may think to yourself, well, I'll just submit one just in case. It's a waste of time for you, and it's a waste of time for medical reviewers if you do that, because then we have to sort through requests that are not valid. So if you don't bill on a 13X type of bill, you don't need to submit it. In today's event, we're only going to be discussing the implanted spinal neurostimulators and the review findings associated with it. So as we move on, let's talk about the implanted spinal neurostimulators. There's only one CPT code that applies to this review, for this prior authorization review in the hospital outpatient department setting. And that CPT code is the 63650, which is implantation of spinal neurostimulator electrodes accessed through the skin. So this prior authorization process applies to providers who plan to perform both the trial and permanent implantation procedures, as it's the same code for both. So we are going to talk about this a bit more as we move on. But if you are planning on doing both the trial and the permanent in the hospital outpatient department, the good thing is you only need to make one prior authorization request indicating, as such. We're going to issue a provisional affirmation on the trial, and if it's still medically necessary to move on and do a permanent, and you're within 120 days from the day we give you that unique tracking number, you are then able to do the permanent and place that UTN and bill it for your permanent placement without asking for another prior authorization request. So all of that information and the coverage requirements are actually listed in our national coverage determination. And that national coverage determination is on your resource page. But I am going to ask Jennifer to place a link to that, just in case you need it, into the chat. So as we move on, let's talk about the coverage criteria for this service. So following the coverage criteria that's listed in the NCD, and again, that NCD is 100-03, Chapter 1, Part 2, Section 160.7. And Jennifer placed a link to take you right into the Medicare coverage database that takes you right to all the information just on the coverage criteria for electrical nerve stimulators. So you don't have to go through the whole manual of 100-3. We're going to talk about the general classifications of the peripheral nerve stimulators that are used to treat chronic intractable pain. So the implantation of the stimulator is only used or should only be used as a last resort. And that's for patients with the chronic intractable pain. We need to know that it's not the first go-to treatment for your patient. So part of your conditions of coverage are that you provide other types of treatment modalities for the patient, and you document and tell us what those treatment modalities were and how they've been tried and how they failed, or how maybe they were contraindicated for your patient. Really, with respect to the items of other treatment modalities, such as pharmacological or surgical, physical, or even psychological therapies, your documentation needs to support that these were tried and did not prove satisfactory, or they're judged to be unsuitable or contraindicated for your given patient. So that's the #1 component of the coverage criteria for doing these implanted neurospinal stimulators. As we continue with the coverage criteria, it's crucial and a must-have component of coverage that the patient really also has undergone careful screening, evaluation, diagnosis by a multidisciplinary team prior to implantation, prior to trial implantation. That that's a huge must. It must include psychological as well as physical examination. And I'm going to say that the psych evaluation must be completed and included prior to that temporary placement. It's a big issue for us to issue a non-affirmed decision on initial request. Also, you need to make sure that all equipment and all the professional and support personnel that are required for the proper diagnosis and treatment and training and follow-up of that patient, all of those people are available and when necessary have seen and treated the patient, if needed. This is something more on seeing within your facility that these people are part of this. That's something the state's going to come in and potentially audit for you. We would only be able to see in the documentation that the necessary people completed the necessary tasks. But know that that is part of your coverage criteria. All right, so let's move on and talk a bit about the trial. Trial insertions are performed to make sure that a permanent insertion will actually provide adequate pain relief. So you're trying it out. When you perform the trial, the generator must remain external. The CPT code that would be used to report the trial is the same as the one that's used for the permanent. So that's the 63650. Remember, if you're planning to perform both the trial and the permanent in the hospital outpatient department, you only need to submit one prior authorization request before you do the trial, so long as you are performing that permanent within 120 days of that prior authorization request decision. So if a trial was done in the office, but a permanent's going to be done in the hospital outpatient department, then you would need to submit a request for the permanent. We would ask that you then also submit evidence that the trial worked for your patient, because that's something we're going to look for, and that there is actual pain relief from the trial, and that they met the other coverage indications, you know, such as the psych-eval as well. So specifically in the trial insertion, if you don't do that in the hospital outpatient department, things that we're going to look for, and we'll touch base on this more, are at least 50% decrease in pain or 50% decrease in the use of pain medications. And again, we'll touch on that a little bit more as we go through. So for the permanent insertion, the electrical leads, you know, in the permanent insertion are advanced into the epidural space to a specific level. And then the battery and generator and the leads are then tucked under the skin and anchored in. It's common that these are done with bilateral leads to allow for placement on the left and right sides of the spinal column. So just as with the trial, you would bill these using the 63650 and report the unique tracking number that was obtained through your prior authorization request. Now, keep in mind, as we mentioned before, if you're doing both the trial and permanent in the hospital outpatient department, you can make one request and you can use that unique tracking number to bill for both procedures, as long as you have not exceeded that 120 days that that unique tracking number is valid for. So if you didn't get a prior authorization for a trial because maybe it was done in a different setting like an office or an ambulatory surgical center, then you would need to obtain a prior authorization request for the permanent and report that affirmed UTN when you bill the permanent. So permanent insertion with multiple leads. Now, there may be cases when your permanent insertion has multiple leads. If you're placing 2 leads, then you would follow all the guidelines that we already have spoken about for the permanent insertion, as well as report the 63650 on the claim for the first lead and use a modifier of 59 to bill the second lead. You would use the 63650 to 63659 CPT code for each additional percutaneous lead placement. In this case, you would not use the 50 modifier nor the right or left modifiers. So know if there's multiple leads and you're reporting the 63650 multiple times, you would need to build that with the 59 modifier. All right, and then other things we get questions on are replacement stimulators. So what happens if you need to replace a generator, like when the battery wears out? So if it's just a generator replacement and not the leads, you would not need to obtain a prior authorization request. And that's because the generator alone would not be billed using the 63650. Most likely that would be billed using something like the 63685. Remember, this prior authorization process is specific to the 63650 in the hospital outpatient department. Again, that's the implantation of spinal neurostimulator electrodes, and that's accessed through the skin. However, if you're implanting a new percutaneous lead in a different spinal level, then that is a new procedure. And the electrodes then would be billed on the 63650, and you would have to follow all the same coverage criteria that we listed before. All right, so now let's move on and talk about some documentation requirements for your prior authorization request. First and foremost, you must indicate what procedure this is for. Both the prior authorization request form and in the documentation need to indicate, is this a trial or is this the permanent? So we're going to look at both places. Since they use the same CPT code, it is your responsibility as a performer of the service to make sure it's evident in the documentation as to what procedure this is for. Is it trial? Is it permanent? Is it trial and then permanent? And we'll show some examples as we proceed on. Office notes must be included. The office notes will be crucial to understand what condition the patient has that warrants a spinal stimulator. It will support the physician's evaluation. It's going to contain evidence of what other methods have been tried and what other methods have failed. As well as it's going to give us indications of if there was any prior surgeries, if there was any medications, etc. So as we move on and we talk about the psych eval, documentation has to support the psychological evaluation was completed by an eligible provider. And the eligible providers are, there's actually a Medical Learning Network article, and I'm not sure if I gave that to Jennifer or not, but I'm going to place it in the chat because I have it right handy. And in that MedLearn Matters article, it does talk about eligible providers for this service. So it includes psychiatrists, clinical psychologists, or even clinical social workers. So the documentation from this provider must include evidence that the patient has an understanding of the procedure, can cooperate during the procedure, and has a reasonable expectation of the trial outcomes. Moving on a little bit more about the psych evaluation. So what we're looking for is documentation of evidence that there weren't any psychological barriers before proceeding with the SCS trial. We're also looking to see if the patient is a good overall candidate for the procedure. Also, we are looking to see if there's any kind of psychological reasons or treatments that may benefit the patient as opposed to just going to a surgical procedure that involves, the spine. So to reiterate, some of the things we're going to look for on medical review are there any barriers noted? If there is a barrier, it was followed up on when the patient, when they identified this barrier, and it's something that either the patient can work through or the patient can work with another provider to work through before proceeding with the SCS. Evidence that the beneficiary was a good candidate for the spinal stimulator. And there's not any other psychiatric treatments that may have benefited the beneficiary prior to proceeding with the trial insertion. If treatment was recommended prior to the trial, we're also going to have an expectation that your documentation contains the information that it was completed. So whatever the recommended treatment was, we want to see evidence that that was completed prior to you moving on to the SCS trial. All right, and then additional documentation to note. If you're providing the permanent placement and you didn't have to seek provisional affirmation for the trial because it wasn't performed in the hospital outpatient department or it was performed at some other hospital in their hospital outpatient department, then you must submit documentation to support that that trial was successful. So on this slide, we've included information on how you support that. So we're going to look for documentation of pain relief. So what the regulations say and the NCD says, to support that that trial was successful, we need objective and measurable information. Not just that the patient reports less pain, but you're measuring how much less pain. We're looking that there's evidence of at least a 50% reduction of targeted pain or a 50% reduction of analgesic medication use. So if your documentation must include the length that the trial went on for as well. Remember, your unique tracking number is only good for 120 days. If more than 120 days passes between the time you obtain that provisional affirmation and UTN to the time that the permanent insertion is planned, you are going to need to request a new provisional affirmation. So again, let us know in objective and measurable terms that the trial worked. A patient, I feel better, I have less pain, doesn't give us any information. We can't quantify that 50% reduction. All right, let's move on and look at some actual prior authorization examples. So prior authorization request example 1. This is a snippet of a prior authorization request. So you can see on the screen the anticipated date of service is October 31st, 2024. And the type of bill is 13X. And the HCPCS code being requested is the 63650. If we stopped here and didn't have any additional information, this wouldn't give us the information we need. We don't know if it is the trial. We don't know if it is the permanent. However, in this example we have here, they're asking for permanent only, and that the trial was completed actually in August in the physician office. So as we move on, let's talk about this example a little bit more. In this case, you would only be submitting for the permanent insertion. So remember, if both were going to be done, you should say that on the prior authorization request form as well. Remember, the documentation that I said would be necessary in this case. If you're doing permanent only, you're going to have to provide proof that there was a trial and that that trial provided relief. And you can support that by showing us that there was at least 50% pain reduction or 50% medication use reduction, as well as all the necessary initial documentation to show medical necessity, like that psych eval, like any other pain relief mechanisms that have been tried and failed. So refer back to those documentation slides as well as the slides about the permanent and the trial. All right. Using the same example, but it's modified a bit, we have the same date of service and type of bill listed up here, the 63650 for 1 unit. And now the additional information says the trial and permanent are to be completed at the same facility. The trial is to be completed 10/31, and the permanent is anticipated within 90 days of that. So before the 120 days would expire. So as we move on, since the trial and permanent are both being done at the hospital outpatient department, you only need to submit one request and indicate as such in the additional information. If we grant a provisional affirmation, the prior authorization for that prior authorization request, your unique tracking number again is valid for 120 days from the date we affirmed it. And again, it's granted for both the trial and the permanent. So you are provisionally affirmed to do both as long as they both occur within that 120 days. As far as the documentation is concerned with this one, we need all the pre-trial documentation that we discussed. So that includes your psych eval, your physician evaluation, history and physical, any tried and failed pain modalities, etc. Since you have not trialed a procedure yet, you would not have the information on how they did and the amount of pain relief with the trial. All right, so let's move on. The last example, modifying the same example. And now in this one, we're requesting a trial only. The permanent placement is going to be completed at a different facility. So perhaps this patient is a snowbird and will winter in a warmer state and have the permanent insertion placed there. Maybe that's something that the physicians have already worked out. The facility would be responsible through their MAC or the prior authorization request for the permanent, but your facility would be responsible for the trial prior authorization request. So in this case, we have trial only. So as we move on, again, this is a request, trial only, permanent being done at a different facility. Keep in mind that if you are an ambulatory surgical center, a prior authorization request is not necessary for either. So if you are the other facility and you're not an ambulatory surgery center, or if you're an ambulatory surgery center or physician office or something like that, then there's no need for a prior authorization request unless you are a hospital outpatient department. Again, in this case, since we're only requesting the trial, the documentation would need to be the same as we just discussed on the prior slide, where you only have as much information as you do before performing the trials. So psych eval, evaluation by other medical personnel, multidisciplinary treatment team involvement, and failure of other kinds of pain-modifying modalities. All right, which takes us to some common medical review findings. So these last couple of slides contain the most common reason codes for this service. Remember, if any of these items are indicated as part of your prior authorization request decision, you can still gather the information and submit to get an actual affirmed decision before trying and billing, or before performing and billing the service. So the first reason code is the HP 605. So this is the #1 reason for non-affirmed decisions. And not surprisingly, it's the psychological screening submitted for services prior to doing the implantation. Remember, this is part of your conditions of coverage, and we have to have proof that the psychological screening is done, and it's got to be present and submitted in your documentation. So the next issue is not supporting the medical necessity of specific conditions that support the need to have this service? Is there documentation of chronic intractable pain that could not be relieved by other means, such as medications, rehabilitative therapy, maybe even psychological therapy? If this request is for a permanent and a trial has already been done, did you send the information to support the 50% pain reduction or the 50% reduction in medication pain? So these are some of the reasons you may see this reason code, the HP 600. The HP 602, insufficient documentation to support the conservative measures. So supporting these conservative measures that they've been tried and they failed, that's key to help supporting the medical necessity of moving on with implanting a neurostimulator into someone's spine. So what medications have been tried? What was the effectiveness of those medications? What therapies have been tried? What was the effectiveness of those? Did you give us pain scales before and after those that helped to support, those things did not affect the patient's level of pain? Remember, as the facility that is requesting the prior authorization of these services, it's your responsibility to obtain information from the physician's office. So when requesting this information, make sure you are letting the provider office know that you need the documentation, the physician notes, all of that information that supports these conservative measures, that they were tried, that the documentation supports they failed. This is where I really have to stress that as a Part A facility and a Part B, you gotta play nice together, because it's gonna take both of you to get these prior authorization requests affirmed on your initial try. All right, next issue is the proof of the multidisciplinary team. So again, before you do the trial, you must have documentation to support the multidisciplinary team approach. And again, this has got to include psychological as well as physical evaluation. And I can't, again, stress enough, this is where your Part A's and your Part B's must play nice together with each other. And you have to do that in order to ensure that all documentation that the facility needs to submit to support, this prior authorization request is given to the facility so they can make the request, so they can move on, perform, and bill the service. All right, and finally, the least amount of errors, but still errors occur here, is when there is no proof that there was 50% reduction of that targeted pain or 50% reduction of the analgesic medications with the temporary trial. So this is probably so low is because most requests are made for both the trial and permanent. However, like we talked about many times, there are instances when a prior authorization request may be for one or the other. For instance, if a trial was done in the office setting or ambulatory surgical setting, but the permanent's going to actually be done in the hospital outpatient department. So remember, when this happens, you do need the documentation to support that the trial stimulator helped. And you do have to provide us that objective and measurable information so we can see that there was at least 50% reduction in pain or 50% reduction in medication. All right, which takes us to our resources. So this is just a variety of different resources for you if you want more information on the service. And these are hyperlinks, so you can go ahead and click on those from your handout and go right to those links. Now let's recap what we covered today. My objective was that you learn about how to properly make prior authorization requests for these implanted spinal neurostimulators so you can get an affirmed decision on your first request. And I think we actually achieved this today by going over all the information on the coverage criteria and the documentation, and even highlighting those common review findings and how you can avoid them. So at this time, we're going to move on to the question and answer segment. And I'm going to ask Jennifer if there are any questions that have come into the chat. Jennifer?
There's no questions in the chat right now.
Perfect, thank you. If you have a question, go ahead and place that into the chat. But in the interest of time, I'm going to move on with some of our closing remarks. One thing I do want to make sure that you guys know, per change request 13754, CMS has directed MACs to disable the beneficiary eligibility information in our IVRs, or our interactive voice response system. And that has to be done by the MACs by March 31st. We are actually removing it by 1/1/25. So your handout may still say March, but we have actually made the decision to disable that by January 1st. This is to help protect beneficiaries from Medicare fraud. So disabling the IVR eligibility means that eligibility is inaccessible to callers, but it's not going to be removed from our system yet because this is a pilot that involves most MACs. We will, again, be removing that access by January 1st, and even though your handout says 3/31, we made that decision the other day. You're still going to be able to check eligibility, though, using our online portal. You can use DDE or even HET to find that information. Again, at this time, it's only being disabled if CMS proves the pilot is unsuccessful for whatever reason and they choose to discontinue it, we can turn it right back on. I don't see that happening since it's really a matter of privacy, but know that that's how it is happening at this time. And we're going to have a lot of education going forward. Education that'll be 2 times a week at the end of November and all through December. So we do encourage you to watch for that information or those educational events to post, and make sure you take advantage of those educational events if you're one that has to check eligibility. All right, following this event, you're going to receive an email that looks like the information here on the right-hand side of the screen. This email contains your contact hours and your certificate of achievement, should you need those for continuing education. It's also going to contain a link to our survey, which we're going to talk about in just a second again. Should you have any follow-up questions, if you think of anything after that event, all is not lost. You can go ahead and send those to us at this email listed here on the screen, and that was put into the chat at the beginning of the event, wps.gha.education@wpsic.com, and send that information to me within the next week. Please don't send any PHI or PII. Remember, we don't have access to the claims processing system, so if you need to find out information about a specific claim, you do have to direct those questions to customer service. After the webinar is complete, any of you who logged into the webinar, again, are going to receive that email. You're not going to receive that email if you called in only. That email, again, contains your proof of attendance and contact hours, but if you need them, just please, and you only called in, be sure to email us at that email I just stated, and we'll send you out proof of attendance. You have to send me your phone number as well. All right, and finally, as I stated at the start of this presentation, we value your opinion. We want to hear from you on how we did on this event. Jennifer placed a copy of the survey link in the chat, and I do encourage you to go ahead and take that survey right now. It only takes a few minutes to complete, and that's why we want to give you the opportunity to take it now. Also, your opportunity to tell us what you want in the future. So let us know how this event was. Let us know what additional education will be beneficial for you in the future. All right. So on behalf of Jennifer and myself, as well as all of Medical Review, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.